Hello, everyone. Can you hear me all okay? Yes, good morning. A very warm welcome to you all to the webinar on Hospital at Home on a very sunny morning here in London. I've strategically positioned myself to showcase where I am geographically in the world, as we have some speakers from elsewhere. A very warm welcome to my panelists and also to everybody who's attending here today. Hello. My name is Ida Yousefi. I'm the Chief Commercial Officer here at Huma. I'm a previous customer of the Huma digital health platform, and I have been humbled and extremely grateful to be part of the team to provide digital virtual ward solutions to COVID patients during the global pandemic, both here in the UK and in Germany. Welcome to my esteemed panelists who have agreed to join us for this hour-long conversation that we will be having. I would like to introduce the team and then give a short introduction of the objectives of our webinar today, after which each of the members will give a short presentation, and then we will open to panel discussion and questions from the audience, which you can place into the chat. So welcome to Dr. Matthew Knight, Consultant Respiratory Physician at West Hertfordshire Hospital NHS Trust. Matthew will be sharing with us his case study on the digital COVID virtual wards, both on Wave 1 and Wave 2, sharing some of the benefits and potential opportunities for expansion. Professor Oliver Oppitz, Director of the Coordination Office at Telemedicine University of Heidelberg, will be sharing the Germany implementation of remote patient monitoring at scale in the primary care setting, in particular during the peak crisis, giving us a bit of information about how our German patients responded and potential future use of remote patient monitoring in Germany as a whole. Tim Strawn, welcome as Director of NHS at Home, Personalised Care, NHS England and Improvement, who will be sharing with us some of the strategy on advancing the NHS at home and showcasing some of the key efficiencies, which I'm very excited to hear about, and potential opportunities moving forward. And last but definitely not least, Cheryl Crocker, Patient Safety Director at the Academic Health Science Network, who will be talking to us about the importance of the design of the clinical pathways to improve decision-making and indeed also patient safety. The COVID pandemic has exposed fragility and inequality in healthcare systems and society. And the pressure on the healthcare system has been acting as a catalyst to accelerate the shift and change in the way that we care for patients and the way in which research is actually delivered to. Today, what we hope to do is three things. We want to explore how our teams have innovated to provide hospital-at-home solutions during the COVID-19 crisis, and also what's needed to maintain this momentum of change. Second thing is, what is the future direction for hospital at home post-pandemic, and what will accelerate or prevent the adoption of this scaling? And then finally, an evaluation and evidence, which has been hugely required to support the case for this change. So before I hand over to our first speaker, Dr. Matthew Knight, I will just move to the polls. We should have a poll question that you will have 10 seconds to answer. I encourage you all to pop onto you should be able to see the question. Have you seen the positive impact of digital virtual wards to remotely monitor and manage patients? There we go. And the result is 78% yes, 21% no. So hopefully by the end of our 1 hour long conversation today, we will have a higher number of yeses with regards to the impact of virtual wards. Over to you, Matthew.
Okay, so this is where I see the technical challenge of whether I can actually bring the slide. Do I need to? Oh, it's up.
No, and Rob does everything for us. Thank you.
It's always tragic when you're giving talks in virtual medicine. You can't work, you can't drive a PowerPoint slide. So
absolutely.
I'm a respiratory physician based in Watford General Hospital in West Hertfordshire. I'm just going to briefly present a couple of slides on the outcomes from our virtual COVID wards in Wave 1 and Wave 2. So let's move on to the next slide. sorry, next there, thank you. So we currently run 3 virtual hospitals, or about to. Our COVID virtual hospital started just over a year ago now, and we've managed over 4,500 patients with COVID through that virtual ward. We literally this week have started running a virtual hospital ward for patients with COPD and are about to start running a heart failure virtual ward. Briefly, just to highlight that these are the difference between COVID virtual wards and oximetry at home services in the context of COVID, that the virtual ward is really an extension of the hospital and has a lot of similarities with the way that patients will be seen within the hospital with, in our case, in effect, daily ward rounds and daily contact between the medical and nursing teams and the patients at home. The oximetry at home services set in our own locality are primary care supervised and led, but they encourage a lot of self-monitoring and self-escalation of patients. This is the clinical pathway that we used during Wave 1, and I will present presently the clinical pathway we currently use for the COVID virtual hospital. But we drew patients from the A&E department, the medical take. We didn't have a oximetry at home service running locally within primary care at that time. So there was a mix of what would now be primary care type patients and secondary care patients. Our entry criteria were cobbled together around my dining room table with a few colleagues beginning of March based on the evidence base that was there at the time. And we have modified these a little bit. But in essence, if you met the entry criteria, on day 1, you were reviewed by a respiratory consultant in the virtual clinic and triaged into a low risk and high risk pathway. And the importance of this was around the intensity of follow-up rather than any particular treatments at that time. Patients in the high risk pathway were called on day 1, 2, 3, 4, 5, 7, 10 and 14 and more often if necessary. And this was obviously quite a labour intensive process. Published some of our outcomes. I put the link in the top right hand side of the slide there for the first 900 patients from Wave 1. The average age at that time was 54, ranging from 18 to 97 years of age. The average number of comorbidities was 2 for our patient cohort. So this was not a young cohort of very healthy gym goers. These were patients who had other medical problems. Just under 9% of patients had a post-discharge complication, and that was primarily progression of COVID, so hypoxia or a bacterial superadded infection, and just under 7% of the whole cohort required hospital admission, although slightly higher numbers in the highest risk cohort. And the overall mortality was actually just over 1.5%, but in the highest risk cohort, we had a 3% mortality, as would be expected. And I think it's important to say that this cohort of patients, there were no apps, so it was a tech-enabled ward, but the technology was the telephone and a pulse oximeter at home. There wasn't much else going on in that first cohort of patients. So given that we felt that we were struggling to manage that, we were running a 7-day service, 9 till 7. We consumed pretty much every free pair of hands that we could find and had a large clinical team running this virtual ward. We approached NHSX somewhere towards the end of March of last year with a request or a plea, I think it was, or a beg for help, trying to automate. In essence, they ran a project with us and Huma Medipad to deploy an app to help us. From our side, the primary driver at the time was to be able to manage more patients. We were managing 400 patients simultaneously, and that was pretty much killing us at the time. So we wanted an app that would allow patients to transmit their data around their symptoms and symptom severity, as well as data around their oxygen saturation, temperature and pulse rate to us, to receive some acknowledgement of the fact that we had looked at that data, but not necessarily a telephone call every day. Interestingly enough, patients gave great feedback about this sort of WhatsApp double tick thingy that's next to the data they'd uploaded. That was a very popular feature, just knowing that we'd looked at their data. The clinicians would have had a dashboard of this sort of nature, which was RAG rated, red, amber, green, so that the clinical team's attention was drawn to those patients with the most concerning pathology, be that symptoms or physiological data. We have published, and I put a link at the end, we analysed the amount of time spent on the first 56 patients, just because of the time frame that we did it over, the first 56 patients that used the Medipad app versus the rest of the patients managed within the normal service. So this was May of last year. And there was just over a 50% reduction in the amount of time per patient using the app. And for clinician time, so putting this into context, we spent about 1.25 hours of clinical time, so consultant time per patient over 14 days. and we saved just over half an hour per patient over 14 days. So this was pretty significant and meaningful. It meant we could manage more patients simultaneously. And as we got out of wave 1 into that sort of nice little hiatus between wave 1 and wave 2, we were actually able to return to doing normal clinics that were not COVID related sooner. So we modified our clinical pathway. In essence, we had the pathways for those people who were digitally excluded, which were to the left and right of the slide, which were basically the same as what we did before. But down the middle were those patients who had an app. They had less programmed telephone calls, but more reactive telephone calls. So if patients loaded data or symptoms or physiological data that was abnormal, we proactively contacted them. If they didn't load up data, which happened quite often towards the end of 2 weeks, patients are pretty bored and fed up of loading data. They just wanted to get out of their house and were fed up with quarantine, which was 2 weeks at that time. We would chase them up just to make sure that they were okay. And this is the clinical pathway we currently use. In wave 2, we've had over 3,000 patients come through the virtual hospital, and the balance of high risk versus low risk was much higher. So over 2/3 were higher risk. About 330 used the app during that wave, and we estimate that saved about 160 hours of consultant time through the last week of December, January, and the first week of February. And we started to appreciate really during wave 2 the importance of high quality monitoring equipment. As we had a higher risk cohort of patients, we had more patients with saturations around the 92, 93, 94%, and we needed to know that that data was as reliable as possible. So we started using, what was the term, clinical grade probes, a lot of probes from Masimo, Nonin, and other manufacturers that our engineering department were happy gave a high fidelity of data. Our readmission rate, despite a higher complexity of patients, was still under 10%, and our mortality rate was well under 1%. And we feel the key to this is actually getting good patient selection. So we use the SOAR score as part of our triage process now. The score, but the link there was worked on and validated by our team and compared against an external validation cohort and ISARIC data. But we wanted a front of house test that didn't require lots of gadgets and x-rays and bloods to be done to allow rapid referral into the virtual hospital, or a rapid decision to admit the patient, get them out of A&E into a ward for further assessment. Many of those patients were subsequently managed in the virtual hospital, but they had the benefit of a more intensive assessment in the hospital. As we move forward in the last few seconds, we're trying to replicate the real ward in the virtual domain, and central to that is this idea of a central monitoring hub, or rather akin to the nursing station in the ITU, that the specialist teams will come and do their ward rounds on a daily basis, reviewing the patients normally in the morning by telephone call or telemedicine contact, but that there's a stream of physiological data coming through during the day that needs to be monitored and acted upon and escalated to the clinical teams if that needs to happen. So we're currently using sort of continuous remote monitoring devices that allow us to calculate the new score and screen for abnormal physiology. And we're planning to do this for 12 hours per day, 7 days per week is our aim, with decisions made about whether to readmit patients. But at the moment, that's heart failure, COPD, and COVID, but we're looking at other potential virtual hospitals, including even some surgical ones. And a few points maybe to come up in the questions around some of our reflections, but reliability of the clinical data, high quality data is absolutely necessary. Patient experience, very little emphasis has been put on the patient's experience during wave 1 and 2. I think they all appreciated this was an emergency situation. However, if we're going to continue with these virtual hospitals, there needs to be much more study and engagement with patients around the type of services they want, how we handle patients who are digitally excluded. A little bit of study around readmission avoidance. Our data shows a readmission even at 3 months of 10.9% and just under 10% within 28 days post-discharge. National data from Cambridge County and team suggests about a 30% readmission rate over 90 days for patients post-COVID. And whether there's a role for virtual hospitals in reducing emergency readmissions, because we have patients who we brought in for scans on same-day emergency care pathways, but they've not been readmitted through an A&E department. And then finally, how do you select patients who are suitable for home care? The various issues in the sort of medical press at the moment. The centre one is a list of the scores, comes from the BMJ paper, myself, Trish Grinoch, Matt Nartakim, and others published a week or so ago. But scores that are currently used, the 4C score from the ISARIC dataset, SOARS, Q-COVID, News2, Recap score, none of these are perfect at predicting which patients are suitable for virtual hospital management. So we need to keep a close eye on this data. If we get the selection right, then we'll have the fewest complications possible. There we are. And there's a few links to various articles and papers that have been mentioned in there. That's me done, so hopefully I didn't go over time.
No, that's perfect. Thank you very much, Matthew. We've got some questions coming through, and we will answer those at the end of the panel discussion as well. We'll just make a note of them, and if there's any of the panelists that would like to answer those specifically, please do note that next to the question. Over to you, Professor Oliver Opitz.
Great, thank you, and thank you, Matthew, for that great introduction, covering all the bases people need to know about the virtual ward. Great work. So I want to give you a slightly different perspective, more on the primary care setting, and just for the audience in a nutshell, what we are and where we come from. So I'm heading an institution at Heidelberg University, which in essence is a health innovation facilitator. So we function as a catalyst for digital innovations in medicine and overall innovative healthcare solutions, not only in the COVID setting. And our aim is to identify innovations and transfer them into the healthcare system, which is very often the bottleneck, and at the same time provide scientific support and evaluation. As we all know, the COVID-19 pandemic, initiated a huge dynamic in digital innovations. And I brought you, I think, a striking example how things evolved in Germany. So in 2017, only 1.8% of physicians in practice offered basic video consultation, although technically this was already all set up. In May 2020, so at the end of the first wave in Germany, 52% offered video consultation, and a further 10% were about to set up such a service. So a huge increase due to the COVID-19 pandemic. And there wasn't only an increase in digital tools, there was also an increase in the acceptance rate from physicians, but especially from patients using these tools. Since for the first time for a lot of people, the value of these tools was so obvious, and they're probably here to stay. The last poll in Germany, 74% of general practitioners said that in the future, every fifth consultation in primary care situation will be a video consultation. So let's jump to remote patient monitoring and Corona strategies in monitoring. Very early in the pandemic, it was interesting to see for us that there are quite a few tools, and I apologize that slide is in German. It's taken from the Health Innovation Hub in Berlin. Quite a few tools, digital tools in the Corona patient journey at the very beginning, and then later on at the intensive care units. But in the ambulatory care setting, in the outpatient care setting, the usage of digital tools was quite rare, and that's exactly where we wanted to go. So I don't have to go into detail of the strategy since it was just nicely presented, but we focused on the home setting and possibly the quarantine setting. So the strategy was to monitor COVID-19 patients at home 2 to 3 times with vital parameters as pulse rate, respiratory rate, body temperature, and importantly, oxygen saturation. And the data were comprehensively provided to the treating physician in form of a dashboard, which went a great way for data protection rules. And we wanted to implement that in the whole state of Baden-Württemberg, which isn't trivial. It's a state in southwestern of Germany with about 11 million people. So we decided to do that in a stepwise fashion, choosing initially representative model regions in a rural setup, an urban setup, and metropolitan region as a test bed for scaling purposes. And we had a pretty good grasp on the care situation for COVID-19 patients in the state of Baden-Württemberg. Since early in the pandemic, we developed an interactive map with all the COVID-19 treating physicians and clinics on it, as well as test center. So we were had a good grasp of the physicians we need to onboard to first cover the representative regions and then scale it to the whole state of Baden-Württemberg. Importantly, for the COVID-19 patient journey, we connect that to the public health services at the starting point of the journey, and on the other end to the hospitals and the hospital information systems to really cover the journey from the diagnosis up to the hospital admission, which isn't trivial in Germany, since the sectors in Germany, the healthcare sectors, are strictly divided between ambulatory care and hospital care. And I would like to leave it at that, and discuss, leave the rest for the discussion. Thanks a lot.
Thank you very much, Prof. Opitz, for your presentation, and also for Matthew for the case study of your experiences. Over to Tim Strawn, who will share with us NHS strategy.
Thank you, Ida. Good morning, everybody. So my name's Tim Strawn, and I've had the privilege of leading up the national team in NHS England on the rollout of COVID oximetry at home and the COVID virtual ward. And we're now looking at the wider opportunities to lock in some of that learning and benefits for other pathways. So just before I talk about the sort of service model in the future, I just wanted to ask another question, if that's okay, and take a poll of people. So could we put that up, please? So the question is, I'm sure you can see it, but do you think virtual wards are most suitable for A, early support discharge, B, alternatives to admission, C, elective waiting list management, or D, all of the above? I'll just give you a few more seconds, and then I'll read out the answer, or the view. The last 5 seconds. It's moving around quite a bit. Okay, let's end it there. So it's ended up as 2% early support discharge, 13% alternatives to admission, 4% elective waiting list, and 79% all of the above. So obviously a huge consensus that there's massive potential across all of those things. So that's very interesting. So I know Cheryl's going to come on in a minute to talk a bit more about the the sort of the learning and some of the stuff from the COVID oximetry at home and the COVID virtual wards. But I just wanted to talk a little bit about the wider opportunity, really, and a service model that we are working on. It's still draft, so this isn't finished, but it'd be really good to get views on this, because this is something we're trying to get the narrative right around. What's the wider opportunity for supporting people at home with technology and virtual approaches? So what this does essentially is look at different tiers or different levels of need within the population. So starting at the left-hand side, we're thinking about a whole population model, because what we'd really like to get to, obviously, is a very strongly emphasis on prevention, so that everybody, whoever they are, wherever they are, should be thinking about their own health and well-being and how they prevent and look after themselves, and monitoring, self-monitoring, self-management has a massive role for everybody to play in that. And so that's where we'd really like to start, and that would have very low levels, if not necessarily any supervision or management. People will be just monitoring themselves with smart devices, etc., and may choose to put it on a platform or may not. But then we move to the right to what we're calling the proactive care layer, or proactive care at home, which is really where people need a bit more support. And this is really the long-term condition management opportunity. So this is people with one or more long-term conditions that really are at higher risk, higher need, really, that would really benefit from some proactive support, primarily probably from primary care and community, where, again, with personalized care approaches, with strong self-management, peer support, coaching, care planning, can really start to understand what's normal, what's right for them, start to self-monitor again, but then know when to call for help, when to escalate, when to get requirements. So we're looking at areas around blood pressure monitoring for hypertension, we're looking at COPD, asthma, atrial fibrillation, diabetes, some really exciting opportunities there, but holistically. So, you know, quite often people do have more than one of those conditions. And then moving to the right again, we've identified a tier, and I'm not sure we're going to call it anticipatory care yet. It might be coordinated care, because anticipatory care is probably slightly broader than this group. But thinking about those people that have even more complex need, really need coordinated care from multiple agencies, multiple support offers, health and social care, you know, a range of different carers, different sort of clinical needs, where again, technology's got a massive role to play in joining up that care much more efficiently. And so thinking about that as a layer, before we finally move to the virtual hospital, the virtual ward layer, which is very much a secondary care led area, where we see, you know, as Matthew mentioned, huge opportunity around supporting people with a range of different things, whether that's heart failure or COPD or other conditions, which has a much higher level of support. And what we see through all of this is potentially a common platform, a common technology, maybe across all of those. But actually what differs as you move to the right is a different staffing model, or different layers of intensity of support and levels of monitoring as acuity changes and people can move up and down. So the staffing piece of this is really, really critical. And our hypothesis is that actually by using virtual models supporting people at home where appropriate, with technology, high tech or low tech, actually it is a more efficient way of using resources, and particularly staffing resources, which is our key constraint in the NHS. We want to make the most efficient use of our staffing, and our hypothesis is actually by using these remote virtual approaches, actually we could be 2, even 3 times more efficient in terms of the way that we do that. And that's what we'd like to prove, as well as generating a much better patient experience. People do feel reassured by these approaches, as well as we're trying to prove through detailed data collection and analysis, the improvement on outcomes, mortality, length of hospital stay, and other outcomes we're tracking. So hugely exciting, very important that we get this right, not just with the digital stuff, but the data, integrated whole systems approaches with social care. The workforce training and confidence is really important. And running through all of that, and I would say I sort of work with the personalised care group, is this personalised approach. So not a one size fits all, really understanding what sort of support people need and want, and actually how we best meet their needs and wishes. So that's what I was going to say, and I'll hand back to you, Eda.
Thank you very much, Tim. You've raised quite a few questions coming up in the chat there. You can have a think about some of those. That's really informative and welcome. I think the aim of all of these digital health platforms is finding ways in which we can ultimately start to move towards this preventative, proactive care, at the same time not increasing the burden to care providers, but rather ensuring that we are alleviating that burden as best as we possibly can to manage, as you've just said, the staffing concerns that exist as well, with regards to the pressures on the care systems, both in primary as well as in the secondary care. Thank you, Tim. Over to you, Cheryl.
Thank you. I'm going to talk about how the Academic Health Science Network and a group of patient safety specialists called the Patient Safety Collaborative we're able to spread these programs of work at scale and some of the learning and patient benefits that have arisen. So first of all, I'm going to tell you a little bit about the Academic Health Science Network in case you haven't seen it or heard of it. We are part of the NHS, and there are 15 sites at sub-regional level across England. And nestled within those sites are the patient safety collaboratives, so the patient safety specialists who deliver a whole range of patient safety programs. We were originally set up in 2013 on the back of a publication from Government, Health and Wealth of the Nation, to enable innovation in England and the spread of that innovation to improve population health. Our work with Tim in the personalised care department was around the spread of COVID oximetry at home and COVID virtual ward. And this became part of our commission around the Managing Deterioration programme, as it sat very nicely in there and is part of a larger programme called the National Patient Safety Improvement Programme. So our ambition was to scale up as rapidly as we could both pathways and support that scale up by the widespread implementation of tools to detect and communicate patient deterioration in these pathways. So COVID oximetry at home is all about patient self-monitoring, and that can be done via a paper-based diary, or it can be done on a tech-enabled support or an app. The use of the pulse oximeter alerts the patient to seek help as and when they need it through safety netting advice that they are given. So if their saturations drop to a critical level, they know who to call and when to call for help. The COVID virtual ward is really secondary care led and allows early and safe discharge from hospital for those patients who are stable and recovering from their COVID disease in hospital. There are two types of models: a basic model, which consists of remote monitoring overseen by a healthcare team, or an enhanced model, which consists of remote monitoring plus supportive care. And those treatments that were started in hospital but need to be continued in the home setting. And that would include oxygen therapy, dexamethasone, or heparin. We've seen this slide before, but that's just a summary of the two types of pathways. But in reality, many of these pathways have become integrated as health and social care teams work together to provide the best pathway and the best service for their patients. So how did we do this and what did we learn? Well, we set up learning network webinars every couple of weeks, and that brought together all the healthcare professionals in one place to be able to share learning, talk about their experiences and support each other either offline as well as through their experiences and presentations, but through a number of resources. They were set up and stored on Futures NHS. And on the right of this slide, it shows you the different sections of that web page where all these resources are kept. And it just meant that people could save an enormous amount of time by not creating new templates when they already existed and having someone to contact should they need advice around how to set up a new service. We also joined forces with the Royal College of GPs in order to spread the word and share our learning as widely as we can. And they proved to be very successful in the webinars that we ran. So we've done incredibly well as a team supporting the spread of COVID oximetry at home and the COVID virtual wards pathways. So we started the oximetry at home pathway first in November, and then by the 31st of December, we had 100% spread, fully operational pathways, so that every patient in England had access to a COVID oximetry at home pathway. And the COVID virtual wards started a little bit later, but again, we've got over 96% spread of COVID virtual wards across England. And that just leaves around 5 trusts who've been unable for whatever reason to set up their own COVID virtual ward, but have got access to other supportive services so that patients can benefit wherever they are in England. And we've done this because we've been able to work in collaboration with our partners. So NHS England and Improvement, through their commission and their support and their governance, have been instrumental in supporting this pathway. NHS Digital in delivering the data and digital architecture, which is so required to understand our outcomes and how we are improving care for patients, but also to support the longer term evaluation. And our NHS X Partners and Innovation Collaborative was about supporting and providing technology-enabled support for remote monitoring or digital apps through the Innovation Collaborative. And of course, wider than the Patient Safety Collaborative programme, the larger AHSN network has supported with additional resources and support to make this spread at scale. And you can see the take-up of remote monitoring schemes by region here. So every one of our 7 regions in England has access to some remote monitoring. So we have a mixture of remote monitoring apps as well as paper-based and telephone services, so that no patient is excluded. And our patient feedback has been really overwhelming. So a number of our centres have undertaken surveys asking patients how they felt about the service. And overwhelmingly, this has been very positive. Patients felt reassured, they felt confident to be monitored in their own homes, having access to help if they needed, and also knowing that somebody was there should they need to call for help. And in some cases, this prevented hospital admission, which was a real benefit for some patients in our communities, particularly for patients with learning disabilities and autism, where hospital admission would have been a real challenge for them and their family. And we're also getting some early data to support information around the reduction in A&E attendances, reduction in admission rates, shorter length of stays and better outcomes for patients because they've been able to be detected early and they've received appropriate and early treatment. So that's the end of my presentation. Thank you.
Thank you very much, Cheryl. It's really informative. A few questions coming up as well, which may be relevant to yourself. If you'd like to have a look at those, I'll give you an opportunity and then perhaps we can look at them a little bit further in a minute. So opening up to panel discussion now, and I will try to incorporate some of the questions that have come through the chat into some of the questions that I ask. Perhaps first starting with yourself, Dr. Matthew Knight and Oliver, about where do we go to next with the hospital at home solution? In particular, some of the questions that have come up are, you know, have we got validated publications on the findings that you've talked about in your case studies, which I know the answer to, but it would be useful for you to also just share those and for the audience as well to know that you can find those on the link today as well. And we're happy to share them with you after the call. Secondly, the multiple conditions, there's some questions around that. If patients have multiple conditions, how do you see those patients clinicians managing their care? There's some conversation also about social care to healthcare and how we can create some connectivity there. Oliver, I know you're doing a lot of this in Germany with regards to identifying patients and then allowing the opportunity for clinicians to then make the home visit only if required and aiding those social care workers in that setting. Similar conversations going on here in the UK. It might be worth the panel having a think about that in their responses and answers. And then finally, adherence to the application versus actual visits to clinicians either in clinic or in hospital. Matthew, maybe start with you and we can move over to yourself, Oliver, if that's okay.
I've noted down a few of those questions because my memory is not so good to keep them all flying in my consciousness. But so looking at the future, I'm mainly talking about what we're planning locally in Hertfordshire. The way sort of as a trust that we seem to vision that is looking at the different stages of the patient's journey, that there's patients with long-term conditions before they deteriorate when they're healthy. How can we help them keep healthy? The patients who are starting to deteriorate but are not yet at the need for coming to hospital, can we intervene and help there? Can we avoid admission if they do come to hospital? Can we speed up discharge when they're in hospital? Can we prevent readmission and can we facilitate return to health? And so we're identifying in our own trust the largest conditions of COPD and heart failure, but we see a progression into things, for example, post-operative care, appendicitis. In fact, can you go home 24 hours earlier with your antibiotics if you've got a home IV antibiotic service, if you can have remote monitoring of some variety of if you can continue to be cared for clinically. We see a big difference between, certainly in the world of COPD, for example, between the current COPD at home services, which have been running since, Cheryl's going to probably correct me and tell me, but I'm going to say something like 2003-04 nationally, a good period of time they've been running nationally, which are very focused on a single condition with a protocolized management. And I think the whole benefit of virtual wards is that they're as dynamic, hopefully as dynamic as a ward round would be, that you're not focused just on the management of COPD. During the COVID virtual hospital, we managed diarrhea, we managed somebody who had a fall, we managed people who got chest infections, managed people's sort of long-term medical problems whilst they're with us, and in the same way as we'd have to do in a ward. So I think one of the sort of futures here is to have this sort of flexible generalist who's able to manage not just the specific condition during an acute phase of deterioration, but the whole sort of range of problems that may came on. And I saw Christian's questions. Christian's always asking me difficult questions, and you can't reply here, so it's convenient for me. But yes, we have published the data from the first 900 patients. That's linked at the end of our slides. And we'll be publishing the outcomes from the rest of our virtual cohort. We haven't quite reached 90 days yet for wave 2 for some of them, so that's why we haven't started to analyze that data in depth yet, but it has been published. How could you study it better was one of Christian's questions. And I think it's difficult because I think one thing is to do a non-inferiority study, just showing that the standard of care given now is at least comparable to what was given before or given elsewhere. Doing a full randomized controlled trial, I think, would be rather difficult in the context. You'd have to sort of have matched hospitals with similar demographics, some of them doing virtual wards, some of them not, or within the context. Virtual wards naturally select enthusiasts, I think, clinically speaking, who are enthusiastic about that model of care. And the final thing about digital exclusion, I think we have to be imaginative around this. We've had 90-odd-year-olds without any problems managing on services. We've started using, I call them burner phones, but apparently that has some negative connotations. Anyway, we've linked the remote monitoring devices via Bluetooth with phones where we dispose of the SIM card when the patient returns the SIM card. So the patient doesn't need to have a mobile phone. They go home with their remote monitoring. The data is loaded up continuously. They return the phone. We take the SIM card out, wipe it, reset it, and enable the next another person to use that data. So we need to be imaginative around how we engage those who are digitally excluded, and we need to make sure that we've got good, robust solutions for those that are not able to use technology in the same way. And I think we also need to accept that not every patient is suitable for a virtual ward. Some patients will always require face-to-face consultations, and I think that's great. There's no problem with that at all. It's the 50% or so that want to use or are very suitable for using other methods that we need to tend to as well. So those are sort of few thoughts, comments.
Thank you very much, Matthew. That's really helpful. Prof. Huppatz.
Yeah. So I want to start with different thoughts. I think, as you just mentioned, the future, this is always going to be a hybrid solution. So we don't want to replace the face-to-face contact between the physicians or the social care or healthcare provider with the patient by digital tools, by no means. So as you said, one has to be imaginative to how to get patients to these tools, and digital guides are one way we're using in the practices. Healthcare providers who are trained to get the digital competence across to broad spectrum of patients. So, but getting back to the future, I think there are two entry points for the patient to these kind of digital solutions. One is the hospital, as you just mentioned, and this is more disease driven, although it has to be, as a ward has to be open for complex conditions as well. but it's a way to follow up the patient, a way to early discharge, follow up the patient in a situation. Without these tools, he couldn't be discharged already, and those type of things. But the other entry point we're focusing on as well is in the community level. So how could we define primary care of the future with the help of digital and monitoring tools? How can we better the at-home service, sending healthcare providers at home, checking on the monitoring, but also using virtual reality to give access to the patient from the for the primary care physician from his office. So I think those are applications for future services where we can use these tools to better the primary care of the patients in the community, and integrate these types of services in the different stages of care Tim mentioned in his slide.
And Oliver, you mentioned in a conversation with me about the identification of patients that need upward referral in the community and that are being managed by their general practitioners and are being identified for requiring this further referral into the hospital setting or to a specialist setting. That can be easily identified through remote monitoring of these patients, but can be managed safely through their primary care or family doctors or GPs, as the setup is in Germany, and then therefore referring those patients in. And you were mentioning to me specifically around long COVID
exactly.
at the time we were talking here.
Yeah, no, exactly. I mean, this is the patient journey managed by the primary care physician is obviously much easier using these monitoring tools, but not only in the acute setup as we saw in the different examples, but also with the large population we're facing with long COVID diseases, which we all start to learn more and more about, and these patients they don't come with a label yet, so that we don't know exactly how they enter the healthcare system. And I think there the primary care physicians are the important triage system to get these patients to the specialized centers, or get on the other way around the knowledge of these knowledge of these new diseases from the specialized centers to the patients. So there's a great multiplier role for primary care physicians, which can be facilitated by using these digital tools.
Thank you. Thanks very much. That's really useful. I think the use cases in different countries really does stand out in terms of how the systems can aid in different areas. And I think it's important to note that the more sort of agnostic to therapeutic areas or indeed care pathways a platform can be, the more it can be flexible in order to scale within community in the way that it needs to within whichever geography it may be. Tim and Cheryl, over to the two of you now. I'm going to try and incorporate some of the questions as well from the audience. But the core question is, how can we get to this future vision that you spoke so eloquently about, Tim? You've been hugely impactful in ensuring that virtual ward as a solution becomes available to the nation after some of the learnings we had earlier on last year during the pandemic. There's an opportunity for that to go further, as you mentioned. There's a lot of fallout from COVID today, backlog of surgery, requirement for more proactive care so that we can reduce the burden on our workforce. And this anticipatory care is key to that, which you discussed earlier. Could you elaborate your thoughts on the how piece of it to some extent? And there's also been some questions around, a patient-powered safety. What do the patients actually say? How do they feel about that? And I think that plays to both the proactive, preventative, as well as, Cheryl, your conversation and presentation. And also, actually, have we evaluated anything around harm? There was a question on that too, which I think is very important, was, is there a risk of overtreatment, anxiety? In fact, we found quite the opposite, that we really alleviated anxiety through these methods, but it would be great to hear from you around that. And also just inaccuracy of results. People can make mistakes, so how would we manage that? Over to you, Tim, and then to yourself, Cheryl.
Thank you, Sarah. There's a huge amount in there, and we could probably do another hour or two probably to cover all those points. I'll try and cover a few of them off. So in terms of the how, the big picture is we're really keen to promote and push this nationally from a policy perspective. So the planning guidance that was published last week, and I put a link to it in the files, actually references virtual wards now, not just in the reference of COVID, but actually starts to talk about the wider opportunity. So there's something about permission, not that people need permission, but really signaling this, this is the future. There's something about the centre and national team with regional colleagues working up a support offer to make it as easy as possible, because these new ICS systems are really, trying to get up and running, and it's trying to make their life easier, really. So we're working on a number of things that will help, we think. For example, identification tools, for example, that people can run in GP systems that will pull out the patients automatically that would benefit from these types of supports and interventions. So, standard scripts, standard operating procedures, standard protocols, not that people have to use, but just as a starter for 10 could be really helpful, because people are super busy. A workforce, again, is so stretched and exhausted, to be honest. So what we're trying to do is just make it easier for them with some templates and some standard ways of doing it that just make life easier. Plus a bit of money helps. We're trying to get some money out to systems to do that, because that always helps. Licenses for use of software products is really helpful. We're funding some licenses that will help. So it's just little things that add up that actually will make it easier for systems, because I think they want to do it, but they just need a bit of help. There's a big workforce agenda, big training and education agenda to help people move to think about different ways of working, because again, we want to help and encourage that, because it's not going to be a brand new workforce that does this. This is about transformation of an existing workforce. So that's huge. We've got a massive emphasis on inequalities. That's a big part of what we're trying to do. So how do we make sure that we really address the people who most need help? So these search tools, identification tools, we're really focusing on people that have the biggest need, from the most deprived areas, with people most at risk, people with SME backgrounds, serious mental illness, learning difficulties, the people that really need help, because that's a massive area, and that really picks up the digital inclusions agenda. It's so important we have a whole person approach, not a disease pathway. That's why the comorbidities and really starting with everybody, because we do need to start with that, I think is really key. And I think the final point, is evidence and data is critical. So some standardization in the way we code stuff through templates, through hospitals, so that we can routinely collect the data as the part of the byproduct of care, collect it once and use it many times. That really will inform this data and this evaluation. We're putting a huge amount within HR into that side of things, because the evidence will encourage further practice, as well as the good case studies, patient feedback is critical. And importantly, as we move to ICS, is the whole social care agenda. The integration is so important, because these people do need help. So how do we interface it with telecare, the whole monitoring that's happening through local authorities and communities? Huge opportunity. And again, there's some clever people probably on the call that are already doing that. But the interoperability, so that people are sharing records, sharing data, is just so important. But we're at a moment, I think, where the world has moved on and changed, and we're not going to go back. This is going to happen anyway. So it's about how do we help people to make it happen as quickly as possible for everybody's benefit.
Great, thank you so much, Tim. That's really helpful and informative. Over to you, Cheryl.
Thank you. So building on from Tim's answers in terms of the how, we've been able to demonstrate that it is entirely possible to rapidly escalate at pace in the implementation at a wide, at a whole England-wide level. And we do that in a number of ways. So the academic health science networks and the patient safety collaboratives are absolutely skilled in connecting people, making those connections, developing relationships, building on the foundations we already have to support implementation of new pathways or build on existing pathways. And we do that through a number of ways. So we've mentioned our national learning networks and webinars, but also the development of resources and sharing of those resources and sharing of learning, so that people don't reinvent the wheel or make the same mistakes over and over, as well as understanding what's applicable in the local context. So what might work in one place might need to be tweaked in another. And so it's being, absolutely sensitive to those changes that need to be made. And that's quite apparent in the national standard operating procedures that were issued, that people have been allowed to flex those and adapt them to meet their local circumstances and create pathways that are most best suited for the patients that they're serving. In terms of safety, quite a few questions around safety. We've been collecting any safety incidents that arise, and we have a number of ways of doing that through our governance structures. We have a whole safety work stream. We have clinical leads at regional and local level who feed up through regions to the patient safety collaboratives and to the work stream any safety issues that they are experiencing. And then that is fed through to the centre, where these are actioned and then reported back, so that we prevent any future harms. In terms of the question around the future harms around health anxiety and other conditions, we haven't been able to cover data on that yet, and I think that will be something we need to attend to over the coming months and in the longer term. But in terms of the safety incidents that we have uncovered, these have been relatively minor. These have been around how accurate the pulse oximeters are, how they're maintained and cleaned and replaced if they get broken, if they are as accurate in darker skin, and things like that. So we've been able to overcome all of those issues and give advice where it's needed.
Great, thank you very much. And I think to add to some of those safety, I think there's some features that exist within some applications and platforms that allow for, alerting patients and when they have perhaps put something in incorrectly, to try and ensure that. But a retrospective analysis of all of that would be excellent as things move forward as well, to further report on it. Thank you very much, Cheryl. Thank you, Tim. Thank you, Oliver. Thank you, Matthew. Incredible. I hope the audience agree. I think it's been extremely informative 1 hour discussion around our hospital at home and digital virtual wards and the opportunities that exist with us in the future, and also the extremely important and innovative work that our teams have helped us deliver in countries in response to the current pandemic. And I really look forward to doing more of that going forward, as we're not out of it yet and there's still quite a lot to do. Before we close off for the morning, I have one last poll. I'm going to start the poll, and what it is, having heard now the speakers and the discussions, would you continue to lead and support digital virtual wards across therapeutic areas? I'll start the clock. 10 seconds to respond to that. I'll give it a few more seconds in case it's just an anomaly. But no, that's incredible. It's coming out as 100%. Yes, having heard your experiences, so thank you very much to our speakers. Having heard your experiences, your case studies, and of course your future way of thinking on solutions as to how we can get there, Cheryl and Tim, hugely appreciated for that. I think we've got a resounding 100% for, yes, there is an opportunity to lead and develop virtual wards in a digital way, but also to not allow any exclusion at all, and to provide care in a different way using digital platforms. Thank you very much, all of you, for your attendance and for your input.